The OrthAlign Plus system includes knee navigation and hip navigation in a single unit. The knee application is exactly the same as it is in KneeAlign 2. There are really no changes other than a couple user interface changes. The hip application is what's new to OrthAlign. When we started developing the hip application, we talked to several surgeons about why more hips aren't navigated today. And the answer almost universally was the added time and complexity added to the case. Of course, that involves supine registration, placing arrays in the bones, the line of sight issues with the cameras and everything associated with that. To try to adapt our existing knee technology to the hip, we wanted to keep in mind the same principles that have made KneeAlign successful, which is mainly staying inside the sterile field, in the surgeon's incision, in the surgeon's normal workflow. So with those goals in mind, we've developed a system that allows navigation of cut placement, leg length, and joint offset, with everything contained inside the joint without requiring supine registration when used with the posterior approach. To do that, we had to add a few pieces of technology. The first is the addition of gyroscopes to the navigation unit, and that's in addition to the accelerometers that are already there for KneeAlign. What that does is, in conjunction with our reference sensor that already had gyros in it, we can do full freeform 3D navigation of the angle between the two components. You can imagine how that's useful when we're navigating an impactor. The other new piece of technology is an optical sensor in the back of the reference sensor. That's actually used with our registration probe. This is the probe that's used to register landmarks on the pelvis and the femur. And in addition to knowing the angle of this probe at any instant, we also need to know the length, and that's where this optical reader comes in. It reads a barcode as it slides along the probe. The surgeon has an opportunity to input targets for inclination and anaversion. The defaults are 40 degrees for inclination and 15 degrees for anaversion, but they can be changed up and down. The next step is to enter a patient-specific angle that was measured on a pre-op AP pelvis x-ray. That angle is actually measured between the intra-teardrop line and a line connecting the teardrop with the most lateral point on the rim. For this model, it's about 39 degrees. The next instruction is for the surgeon to place both instruments on the bones. There's a pelvic base attached outside the acetabular rim and a femur tracker base that's attached on the greater trochanter. And the exact position or angle of those isn't important, they just need to be well fixed to the bone. I have an option whether or not to register the femur at this time. If I want a measurement of leg length and offset, I need a pre-op measurement before we dislocate the hip. And if I'm not interested in that, I can skip these steps. Now 3 points on the femur, point A, point B, and point C. Now the surgeon can dislocate the femur, make the femoral neck resection, and move on to the acetabulum. There are 4 points to register here. First one is the most superior point on the rim. Next one is the bottom of the notch. The third one is the posterior insertion of the transverse acetabular ligament. And finally, the anterior insertion. Attach the sensor to the jig. And with the shell attached to the impactor and in position, press the button to proceed, wait for the sensors to synchronize, and then move the reference sensor over to the impactor. And here I see my live inclination and anaversion angles, with the target set where I put it preoperatively 40 degrees and 15 degrees. So the surgeon impacts the impactor, and that proceeds to the next screen. This is a snapshot of our last angles, and then moves on to registering the center of rotation. And we pick 3 points on the rim of the shell. Gives us confirmation of our angle, which has changed. And now we're ready to re-register the 3 points on the femur. Put in the brooch or the stem and register points A, B, and C one more time. And as soon as that registration is finished, the system tells me a change in length and offset. In this case, no changes reported. I've put the femur back exactly where I found it. If I wanted to change the length or I wasn't happy with the results here, I could always go back and recheck that, having made changes to the trial neck or head. The basic goal of navigation, of course, is to improve on the surgeon's eyeballs for aligning components. In our case, it's the resections on the knee, or it's the alignment of the acetabular cup to the pelvis. Large console systems have been doing that for years and years. What's new here is that we're replacing the big computer on a stand and the cameras with a device like this that's right here, right in front of the surgeon. No off-site computers, no rep required to push buttons, no special training or capital expense. It's all right here, as much as possible in the same workflow that the surgeon's doing anyway. We try to improve accuracy and get the benefits of navigation without some of the traditional drawbacks, the line of sight, the expense, the supine registration in the case of the hip. And that's what we've done really well with on the knee in the knee line system, and we're hoping to do on the hip. That's been our goal from the beginning, to improve outliers and add as little overhead as possible.